Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing about mastoidectomy and how mastoidectomy is divided into canal wall up and canal wall down procedures. What's the difference between the two and what are the different surgeries that come under each one of them? You can also now purchase my notes. I have added links in the description. Okay, so before we get started with canal wall up and canal wall down mastoidectomy, let's look at the anatomy a little bit and try to remember these few things which will be important in understanding mastoidectomy. So, in the first image that we see over here, this is the image of the boundaries of the middle ear. This is the anterior wall, this is the superior wall, this is the medial wall, this is the posterior wall and this is the inferior wall. So we have the lateral wall is formed by the tympanic membrane. So we have removed the tympanic membrane and this is the cut section through it. And certain important structures to remember here is that this is the adytus. Adytus is how the middle ear is communicating with the mastoid which lies behind this. So through the adytus, the middle ear communicates with the mastoid antrum. Next is, you can see that this is the facial canal. You can see how it is going through the medial wall and then reaches the posterior wall. So that's the relationship of facial nerve canal in the middle ear. Next, if you look at the second image over here, this here we see is the external auditory canal, and we can see this is the mastoid antrum. And the common structure where they are sharing a wall together is this, which is the posterior canal wall. So this is very important for us. This is the posterior canal wall, which forms a common boundary between the mastoid antrum behind and the external auditory canal in front. And somewhere here in the posterior superior part of the canal is where we have spine of Henle. Then let's talk about what is spine of Henle. So spine of Henle is this bony projection. Just a second. Here, it's a bony projection which is found in the posterior superior wall of the external auditory canal. The importance of knowing this is that this spine of Henle, it serves as a surface landmark in mastoid surgeries. So why is it important? Because as you can see, this is the mastoid antrum, and a very well-known landmark for discovering the mastoid antrum is the McEwen's triangle. So the McEwen's triangle lies just posterior to it. So McEwen's triangle is how we know where the mastoid antrum is. So that leads us to the next question, that is McEwen's triangle, which is also known as the suprameatal triangle. Now, how do we form the boundaries of it? So if we look at the image over here, the superior boundary, this we can see is the root of the zygoma. When the root of the zygoma goes posteriorly, it forms the supramastoid crest. So the superior boundary is formed by the supramastoid crest, or also known as temporal line. Anterior boundary is formed by this line which goes along the posterior superior margin of the external auditory canal. So this is our external auditory canal, a line going through the posterior superior margin. This is the line. And the third line is a tangent which is joining these two lines. So this triangle that we have formed here is known as the McEwen's triangle, also known as suprameatal triangle. And the relationship of mastoid antrum to this triangle is that the mastoid antrum lies about 1.5 centimeter deep to this triangle. So it is important to know both of these landmarks, discovering the spine of Henle and the McEwen's triangle, to know where you need to drill so as to reach the mastoid antrum. So these are two very important anatomical structures you should know. Next, there are some more terms that we need to know, like facial bridge or facial ridge anterior and posterior buttress. So we'll look at each one of these because this will be important when you learn the steps of mastoidectomy. So before that, we should first know what is this anatomical structure. So first is facial bridge. So facial bridge is that part of the bony canal which basically posterior bony canal, sorry, which overlies the fossa incutis. So it lies somewhere over here. This is the adductus. Somewhere over here, there's a posterior bony canal wall which overlies the fossa incutis, and that is known as facial bridge. So usually in mastoidectomy, we need to remove this bridge so as to make this middle ear open up completely into the mastoid cavity behind. Next is the facial ridge. Now, facial ridge is this part of posterior bony canal wall which overlies the facial bony canal in the posterior wall. So here you can see that this is the facial bony canal which is passing in the posterior wall of the middle ear. So here, this portion exactly is where we have the facial ridge. So when you're performing mastoidectomy, what we do is we basically lower this facial ridge. And as we lower the facial ridge, we're basically making this into one cavity. However, you cannot remove the facial bridge completely because this lies lateral to the facial nerve canal. So when you try to remove it completely, you can actually end up injuring the facial nerve. That's why the facial ridge, sorry, not the bridge, facial ridge should be lowered. Next, the next term that we have is anterior buttress. Now, what is anterior buttress? Anterior buttress is that part of the bony facial canal which meets the tegmen. So, this is our posterior canal wall, posterior wall of the middle ear, and this is our tegmen, and this is our floor of the middle ear, which continues with the floor of ESC. So, somewhere here, like the posterior bony canal, where it joins with the tegmen, this is known as anterior buttress. And the posterior canal wall, which will be somewhere here, although this is the middle ear, I'm not able to show you an image over here. The posterior bony canal wall, which communicates or joins with the floor of the ESC, that's where is known as the posterior buttress. So these are all the structures anatomically that you should know so as to perform the steps of mastoidectomy. So that brings us to the question, what is mastoidectomy? So mastoidectomy is this operation where we are trying to surgically remove the mastoid air cells which lies within the mastoid part of the temporal bone so as to eradicate the disease and gain access to the middle ear cleft. That is the simplified definition of mastoidectomy. Now, mastoidectomy procedures have been divided into two types. One is canal wall up procedures and canal wall down procedures. Now, right now, I'll be discussing what are the differences between the canal wall up and canal wall down procedures. So, coming to definition. So, canal wall up. Now, if we see at this image over here, this image, I just told you that the ESC over here and the mastoid antrum over here, they share a common wall over here, which is the posterior bony canal wall. When this canal wall is preserved, which is it is intact at the end of the surgery, basically maintaining the differentiation between the mastoid cavity behind and the ESC in front, that is known as canal wall up procedure. And when you completely end up removing this and removing this posterior bony canal wall, and you convert the whole of this thing into one cavity, the mastoid cavity and the ESC is converted to one cavity, and that time it is known as canal wall down procedures because the canal wall has been removed completely. So that is basically what is canal wall up and canal wall down. So in canal wall up, we have preserved the posterior bony canal wall, and in canal wall down, we have removed this posterior bony canal wall, and a common cavity has been formed with the external auditory canal and the mastoid. Now, what is the aim of performing these two surgeries? So, the aim of canal wall up is to eradicate the disease, but at the same time, try to maintain a near normal canal and hearing mechanism. Whereas for canal wall down, we are not trying to maintain a near normal canal anatomy. Here, our main aim over here would be to eradicate disease with wide exteriorization so as to be able to create a safe and a dry ear. That is our main priority over here. Whereas in canal wall up, one of the aims that we are keeping in mind is to not disrupt the normal anatomy of the canal. Next is, what are some procedures that we know which are canal wall up and canal wall down? So, canal wall up, the most common procedure that we do is cortical mastoidectomy. Cortical mastoidectomy is also known as simple mastoidectomy or Schwartz mastoidectomy, also known as complete mastoidectomy. And the second one is a combined approach tympanoplasty. So, combined approach tympanoplasty is when you perform a cortical mastoidectomy with a anterior tympanotomy, with a posterior tympanotomy, with a tympanoplasty. That's what combined approach tympanoplasty is. These are the two common canal wall up procedures. Now, looking at the canal wall down procedures, we have atticotomy, we have atticoantrostomy, then we have a modified radical mastoidectomy, and a radical mastoidectomy, which is the most radical surgery in terms of mastoid. So, these are all the surgeries that you should be knowing about, and what are the steps of them, what are the indications and contraindications. I'll be talking about each one of them separately in separate videos. For now, let's continue with the differences between canal wall up and canal wall down procedures. Now, if we had to look at a generalized, just simplified indications of canal wall up, these would be when the cholesteatoma is it is limited to attic and antrum. It has not spread extensively. In that case, we can still attempt cortical mastoidectomy. Next, very important, we need to also have good eustachian tube function. We should also see if the patient is reliable to come for further follow ups or not, because in canal wall up surgeries, we need to look and follow up on the patient so as to see if there has been any residual disease left behind or how the patient is doing. So, reliable follow ups is one of the most important things you should assess when thinking whether to perform a canal wall up or a down procedure. Also, this is usually preferred as a first surgery unless it is a very complicated disease or a very extensive disease, in which case you should perform a canal wall down procedure. The indications of canal wall down procedure would be extensive or recurrent cholesteatoma, patients who have posterior canal wall erosion. So, if there is already erosion, it is better to completely remove the posterior canal wall and perform such a procedure. Next is if patients have a poor eustachian tube function, it is preferable to do a canal wall down procedure. And also, if patients are less likely to come for follow up for a second look, in that case, we should definitely be doing a canal wall down procedure. Even in cases which are complicated with the different complications of CSOM, intracranial or extracranial, it is preferable to perform a canal wall down procedure. And last of all, last indication would be revision surgeries. We should definitely go for canal wall down procedures. So these are roughly simplified indications of canal wall down and canal wall up. I'll talk more about specific indications to each of the surgeries I mentioned before in a separate video. Next, let's look at exposure and disease clearance. Now, in canal wall up, as I said, because we are not removing the posterior canal wall, we are maintaining that boundary. So, basically, this has the disadvantage of having a very limited exposure. It is very difficult to see areas which are like sinus tympani or the anterior epitympanum or the hypotympanum. These areas are difficult to visualize in canal wall up procedures. Whereas for canal wall down procedure, there is a much wider access with a direct view of all these recesses. And therefore, complete disease clearance is much easier to be done in canal wall down procedure. Next is the risk for recurrence or residual disease. Canal wall up procedures definitely have a higher chance of risk because of the limited exposure of the different hidden areas in the ear. So it has about a 10 to 40 chance of having a recurrence or a residual disease being left behind. Whereas canal wall down has way lower chances, about 2 to 10%, because the disease has been exteriorized. Also, even if recurrence does happen, it is much easier to detect because of the accessibility. Next, looking at the hearing outcome. Now, hearing outcome is better in canal wall up because we are trying to preserve the normal anatomy as much as possible. So, it is easier to perform an ossicular reconstruction over here, and because of the normal canal acoustics being also maintained. Whereas, hearing outcome is often poor in cases of canal wall down procedures like modified radical or radical mastoidectomy. Then, because the cavity has been enlarged, the meatus has been enlarged, the cavity acoustics are less favorable, but ossiculoplasty is still possible in these cases. Next, looking to the appearance of the external auditory canal. So, in canal wall up procedure, the external auditory canal obviously looks normal because we have tried to maintain the anatomy over here. Whereas in canal wall down procedure, we have a widely open meatus which is communicating with the mastoid posteriorly. So, we see a huge cavity right over there. So, now that we have a cavity, so the next difference would be about cavity care. Now, in case of canal wall up procedure, cavity care is not required at all because the ear has still maintained its anatomy. So it is a self-cleansing ear. So no long-term care is needed if the surgery has been successful. But in case of canal wall down procedure, it is important to remember that the patient may need lifelong cavity cleaning follow-ups. That brings us to follow up of the patient. In case of canal wall up surgeries, we need to follow up very strictly. Strict surveillance of the patient is required, and sometimes a second look surgery is also required at about 6 to 18 months. But follow up is very less stringent in cases of canal wall down procedure. Next is, what are the complications of canal wall up? The complications is obviously having a higher rate of residual disease or recurrent disease, and also the formation of retraction pockets. Whereas complications in canal wall down procedure would be more related to cavity problems because of the large cavity that you have now created. You may end up with issues like otorrhea or granulation tissue formation or meatal stenosis. So, all of your complications will be more focused on cavity related. Next, coming to patient limitations. So, in canal wall up, usually the patient does not have any limitation. They are allowed to swim and bathe easily. But for canal wall down procedures, swimming can lead to infection of the mastoid cavity, and so they are usually advised to avoid swimming. Next is auditory rehabilitation. So, because we have preserved in canal wall op, we have preserved the normal ear canal anatomy, it is easy to prescribe hearing aids over here when it is required, like an in the ear or in canal hearing aid. Whereas in case of canal wall down procedures, there is way more problems in fitting a hearing aid because of the large meatus that you have created now. And sometimes even the mastoid cavity can get infected. So it becomes difficult to prescribe a hearing aid to such patients. Next, let's discuss what are the advantages and disadvantages of canal wall up and canal wall down. Let's start with canal wall up first. So the advantages of canal wall up is, the number one is that it preserves normal external auditory canal anatomy. As a result, it also has a better hearing outcome. And there is no large mastoid cavity, therefore less maintenance and no lifelong oral toileting required. Patient does not have any limitations in terms of swimming or bathing once once the ear has healed. And this is also preferred in children so as to avoid any cavity problems. And lastly, they are also better candidates for hearing aids. But the disadvantages of canal wall up would be that, first of all, we have limited exposure because the canal wall is intact. So it is difficult to clear out disease from areas like sinus tympani or the anterior epitympanum or hypotympanum. Therefore, because of this limited exposure, there's also a higher chance of having residual disease or recurrent disease, about 10 to 40%. Next, third disadvantage is it requires a planned second look surgeries. And lastly, there is a risk of recurrent cholesteatoma and retraction pocket formation if the eustachian tube function is poor over here. So these are the advantages and disadvantages of canal wall up procedures. Next, let's look at canal wall down procedures. So the first advantage would be that we have an excellent exposure of the middle ear as well as the mastoid recesses. Therefore, we end up in having more complete clearance of the disease because of excellent exposure. Second is because of this, there is also a lower recurrence or residual disease rate, about just 2 to 10% compared to in case of canal wall up, there's a chance of 10 to 40%. Next advantage is residual disease, even if it happens, it's usually visible and it's very accessible on follow up. And lastly, this is useful in cases of unreliable follow up patients because you do not need a second look surgery. All the disease is cleared in the first surgery itself. So these are the advantages. Next, let's look at the disadvantages. So the first disadvantage is the large cavity that you're creating and all the problems that come along with that. Like it can have different complications, like there could be granulation tissue formation or meatal stenosis, and this will also require lifelong care of periodic cleaning and oral toileting. Second, these patients usually have water restrictions. They cannot go swimming easily because if it enters, it can cause issues. Like it can cause caloric vertigo when there is a cold water or air exposure to the canal. Next, we have cosmetic deformity in these patients because of the enlarged meatus and the post auricular depression that occurs because of the surgery. Another significant disadvantage is that usually these patients have a worse hearing outcome. And lastly, there's a risk of meatal stenosis if their meatoplasty or the cavity saucerization has been inadequate. So these are all the advantages and disadvantages as well as the differences between canal wall up procedures and canal wall down procedures. Amongst the three common procedures that we know are cortical mastoidectomy, radical mastoidectomy, and modified radical mastoidectomy. So just before we finish the class, we'll discuss a little bit about what is it exactly? What is the definition of it? What are the structures that you remove over here? But we'll do a much more in depth discussion in a separate video. So, first of all, is cortical mastoidectomy. If you see in the first image over here, this is the antrum over here, and this is the tympanic membrane. This is the posterior canal wall, which has been preserved over here. So, you can see how we open the antrum and clear all of the mastoid air cells over here, but we do not disrupt the posterior canal wall as well as the external auditory canal. So, cortical mastoidectomy is basically the complete exenteration of all accessible mastoid air cells and then converting these into a single cavity. It is important to remember the word accessible over here. Next is radical mastoidectomy. Now, radical mastoidectomy is the procedure which is used to eradicate disease of middle ear and mastoid, where the mastoid, middle ear, attic, antrum, these are all exteriorized into the external ear by removing the posterior canal wall. Along with this, we remove all the remnants of tympanic membrane, all the ossicles except for the stapes foot plate, chorda tympani, and mucoperiosteal lining are removed, and the eustachian tube opening is also closed by a muscle or a cartilage. So let's look at radical mastoidectomy here. We see how the antrum as well as the ear canal, they have been converted into a single large cavity. This is where the facial ridge lies. So we lower the facial ridge and smoothen out so as to form a floor over here, continuous floor over here. And you can see that the only ossicle that remains is the stapes foot plate. And somewhere here will be the eustachian tube. So we even end up blocking the eustachian tube opening. So we can see a huge cavity over here. This is what radical mastoidectomy is. Third one is modified radical mastoidectomy. This is also a canal wall down procedure where we eradicate the disease of attic and mastoid, and we convert the mastoid, middle ear, attic, antrum and exteriorize them into the external ear canal by removing the posterior meatal wall. But the key difference to remember here is that The tympanic membrane remnant, the functioning ossicles, and the eustachian tube function, these are preserved. So if you see in the image over here, these are the tympanic membrane remnants which is still retained. The eustachian tube opening is not blocked over here. We maintain its function, and whatever ossicles are left, we should preserve them instead of removing all of them. That's the difference between radical and modified radical mastoidectomy. That completes our class today. If you have any questions regarding this, please note them down in the comment section and I'll get back to you.